Hi everyone, welcome to another VITA learning webinar. Today I'm going to be doing the webinar. I'm Jim McGuire. I am a certified dental technician in Crown and Bridge. However, I was raised in a denture family of laboratories, so all the way up in Alaska, Anchorage, Alaska. So I'll be coming to you from the point of view of a VITA worker, but also a technician as well. So just a couple things before we get going. We want to make sure that you understand that your phone is going to be on mute. So if you have any questions on that right-hand side, that panel, go ahead and type in your question. And then when you send that in at the end of the program, there'll be a Q&A session. So, whatever the question might be, I'll try to answer. If I can't, then certainly we'll get you an answer as needed. And then this meeting, this webinar is going to be recorded, and we post these on our VITA North America YouTube channel. You can also visit them on the LinkedIn or the Instagram or even Facebook. We have a ton of recorded webinars. We've been doing these webinars for all year long, and we've got quite a few more to go for the rest of this year. There are all sorts of different topics. We just got through doing some programs with a combination syndrome with Mark Wagenfield that was talked about the how to manage an upper against a lower natural dentition. That was really exciting. We do class 1, class 2, class 3 dentures. We do workshops that also involve digital dentures as well. We've got that coming up at the end of the month of August. So please attend future programs as well. So Centric, right? What is that? What is the favorability to it? But it's a concept of that can be integrated in any setup, regardless of balance or lingualized occlusion. So you just want to have a denture set up, get all the information, all the measurements, all the details, which is the hardest thing to get from some doctors. If there are some dentists online, hopefully you're not one of those, but from a denture perspective, from a dental lab perspective, what's difficult is just getting the correct measurement so we can reduce resets and reduce remakes as far as tissue pressure points and just the denture ill-fitting because we haven't taken a good enough impression and so forth. So we will go through this, walk through this, and put it together. All of us know that there's all sorts of different occlusal setup concepts. A lot of them go back, starting in the 1920s and before, and then they gradually morph into other things, and then they're added on by other dentists primarily, other philosophies around the world. Primarily, we rely on the Gysi as far as a lot of his work done, and then Dr. Gerber as well. But those concepts are, utilized for class 1 through class 3 setups. There's not necessarily one that fits all. However, you need to recognize that a lot of the work, a lot of the concepts are advantageous for any of these setups. Primarily, we do this by a prescription. So we really don't get a lot of information from the dentist as much as we would like as far as, okay, we'll set up a class 1 relationship. Well, but what type of setup philosophy might that be? And that's where we kind of run into problems and so forth. So we're primarily used to balanced occlusions, right? So 2 cycles, which are common for any type of setup philosophy, but we have to understand what kind of a chew cycle the patient has. Is it going to be more deflective, cause deflective contacts? Is it going to be difficult more to have a compensation curve Is it going to be difficult to have a curve of Spee, curve of Wilson, and so forth? And then what we have to also realize is that when the patient chews, of course, even a balanced, balanced working setup, we have a lot of deflective forces that even though it's working on one side, you still primarily, let's face it, you still have the patient chews on both sides simultaneously. So you've got bolus, you've got food in between these teeth on the balance side, and that causes then, deflective forces that we're really trying to avoid. And balance occlusion, the whole concept is that, right, is to avoid tipping of the denture. This is something that's not normally found in natural dentition. This is only for dentures. We have to do this because the dentures flip-flop, they're seesaw as the patient chews. But this type of balance occlusion we've been using for forever, right? And very successful as well. So this is an alternative method to set up denture teeth. So balance occlusion, we deal more with the compensation curve, the curve of Spee, curve of Wilson, follow the pound line. We're trying to deflect those excursive contacts as best we can. We normally do some philosophies talk about a cuspid disclusion, right? And then others talk about group function, especially on implant-supported bridges and or dentures, fixed dentures, right? They're static. They're more like a natural tooth. So we can have more group function so that we don't put all the force on individual teeth. And this is also another key, is that we can go to all the trouble of trying to set the teeth up precisely, but at the beginning, if that treatment planning, if that impression's off, mucostatic impression is off, the model is slightly off, what are we going to have? We're going to have more spot checks, when the denture's processed and tried in. You have to maybe see more grinding because you're trying to accommodate all of these different curves and properties that are relative for balance occlusion to try to provide that functional balanced occlusion simultaneously on left and right side. Whereas you have other concepts as well. However, the balanced occlusion, because it's trying to avoid that denture from tipping, you try to set your teeth, obviously, in the cusp-fossa relationship. You have those stamping cusps. They excurse, they actually flow and deflect and move up and out as the patient chews, because of those individual patient chewing cycles. They're never up and down, but a little bit more of a cycle, a curve, teardrop, and so forth. So we're always trying to function and try to prevent that deflective contact points so that we have tipping of that denture and individual teeth. And then we have like lingualized occlusion, right? Lingualized occlusion, the whole point of lingualized occlusion is to remove most of your deflective contact points. You basically put everything down into one little point that's more of a mortar and pestle type chewing habit. The bolus of the food is still there, but you're allowing the bolus of the food to actually escape, and you're just grinding with that one individual lingual cusp into a semi-flat, plain, lower setup. This was also done by Dr. Giese as well, and then refined by Dr. Payne to kind of understand it better. We usually set these more on a flat plane occlusion, or at least on the lower. And then we have the cuspal, the lingual cusp of the upper go into that fossa. And these can be set up either 1-to-1 tooth relationship for lingualized occlusion or 1-to-2. So between balance and lingualized occlusion, they have a lot of similarities. The only difference really is on that lingual side of the on a lingualized occlusal setup, those lingual cusps are on a flat, straight line, but the buccal, the facial of the lowers, those usually follow the same curve B as you would normally would, so that the cuspid pretty much lines up with the incisal cuspid as well on the bicuspids. So we still develop it pretty much the same way. We start off the same way, but what the lingualized occlusion does is, instead of deflective contact points with the food on both sides of the inclined planes of your buccal and lingual, we're repositioning the force more into the fossa and pushing everything, the food, the bolus, into that fossa, that lower, and then having that upper cusp chew on it. So we're getting away from natural tooth, which is, obviously is in a membrane in the natural jaw with all sorts of occlusal angles, shear forces presented on it. We try to replicate that, but then you have to have balancing and occlusion. And then now to refine it a little bit more, that's where that lingualized occlusion comes in. So when we have lingualized occlusion, we still have those centric stops, but again, they're only in the buccal or the lingual, maxillary lingual cusp going into the stamping cusp. And again, as I mentioned, you can make this into a one-to-one tooth relationship or one-to-two tooth relationship. You can drop out the, first bicuspid. You can switch out, actually take out the second bi, replace it in the first bi, and then use the first bi in the second bi, just to give it a little bit more stability if you want. But if you look at the way that it functions on a lingualized occlusion, you have a system where you have a mini functional balanced occlusion, balance and working, in that the upper maxillary, those linguals, they will slide on the inclined planes about 1 to 2 millimeters and side shift back and forth as the patient chews in their cycles. So you still have stability in these dentures, even though you have only one really centric contact point to pulverize that food. So this is a little bit actually easier for the patient with one contact point to avoid that interlocking of the denture teeth, the cusp fossa relationship when the patient chews. Because you'll find some patients that are going to chew with a standard balanced occlusion setup where you have multiple contact points along the occlusal surface, but the cusp kind of fit in too much into that lower, and then when they try to separate their jaw, they can feel a little sticky, if you want, and that'll pull on the dentures as the patient opens and closes their bite while they eat. So you have to have forces redirected so that you have as much vertical forces straight down onto the ridge as possible, right? Avoid any transverse or lateral forces, excursive forces. So a lingualized occlusion can do this. And then when you look at the ridge itself, there's a lot of patients that complain about pressure points. One of their main chief complaints, a lot of patients is that the ridge may have a sore spot. So what causes that sore spot? Well, it's a lot of different things. Primarily, though, it is a certain place where that the vascular area of the tissue and the underlying bone, there's too much surface contact or transverse forces that are causing a little bit more pressure in one area. They're almost like having an implant case where you set up your denture teeth, but you have premature contact in one place. So all that stress is forced in that one area. So if we can deviate, we can move that force away from a transverse force, lateral force, and go a little bit more vertical straight down onto that ridge. And that way the whole ridge is going to cover most of that stress area. So there's not really one pain point for that patient. So this is something that helps with the patient's comfort by going to a lingualized occlusion type setup. So, there's pros and cons for both, whether it is a lingualized occlusion or a balanced occlusion, right? advantages of balanced occlusion. It preserves the dentulous ridge from resorption because you've got less force on one side versus the other because you got both the left and the right side working together, balance and stability. You've got increased denture stability. The theory was always you need balanced occlusion, the flatter the ridge. That's kind of thrown out the window nowadays. Most patients will tolerate any type of setup as long as we take control of, managing the actual fabrication of the denture, that it fits correctly. A lot of people will just do relines thinking that, well, if they have a sore spot, it must not be fitting correctly. So we're just going to do a reline, then they get it back. And the patient still complains about the same issue down the road in a very short manner. But that's because we haven't looked at the occlusal. We haven't looked at how are we redirecting those forces and helping that patient out. It helps facilitate the adaptation to dentures, right? Patients have difficulty when they first assume on a denture in their mouth because it's different, right? I mean, we do a lot of immediate dentures nowadays. We always have. And patients who are used to their natural teeth working, they don't have to worry about all of a sudden their mouth, their teeth are given away, up and down, rocking up and down, sideways in motion. They're used to just chewing whatever diet they're used to, and then they want to continue that diet. And that's where, of course, we always have to go into more of an implant case to provide that patient with really definitive chewing. And then cross-arch balancing, right? We have cross-arch balancing in which we can secure that denture a little bit more. Disadvantages, of course, you have to adhere to those balancing principles. You have to meticulously set those teeth up in a compensation curve to adequately define the curve of Speed, curve of Wilson, to provide that bilateral balanced occlusion. And if you don't, then you've got, a lot of stress riding on individual teeth, which may not be the best thing. It also requires a semi-adjustable or fully adjustable articulator. It's very difficult to do any balanced occlusion on just a hinge articulator. It's really not done, right? So we also have to, it increases lateral and primitive grinding habits, meaning that the patient is going to start chewing their food differently than what they used to and trying to adjust their bite to accommodate a new set of dentures. May require more anatomical posterior teeth. Usually we go to more anatomical over balance to be able to create that balance act, right? We can tolerate anatomical teeth on the upper and flat teeth on the lower. That is something that happens, but that turns more into a lingualized occlusion, right? Lingualized occlusion, that whole point is that you have more of a flat surface on the lower. However, we found that it's not necessary to have a completely flat lower. We just want to flatten the curve from the lingual to the buccal cusp to make that flat. So lingualized occlusion, right? Aesthetic and function are combined. So they're arranged so that they're very functional. Patient can't, doesn't chew into their side of their mouth easily. We've centralized, we've taken all those forces and kind of combine them and try to create them away from deflective forces, shear forces, lateral forces, and direct them straight down onto that ridge. Motor and pestle, right? Effective mastication. So a little bit more than just a grinding machine on balance, but now you've got actual impact straight into the cusp with a specific cusp of the maxillary upper. The only downside to that, of course, is that because you only have one single contact point on that lingual maxillary cusp, is that's where all your wear is going, right? All your wear of your denture teeth is in those impact areas. But if you have good teeth, stable teeth, well-produced teeth, then that really won't deter from using a lingualized occlusion because they'll last a long time anyway. It provides freedom of movement. You can make freedom of movement on both balanced and occlusion. And what that means is, as I mentioned, the cusp, you can avoid them from locking, the patient feeling that lock, and make it much easier for that patient to chew and chew freely, and work with their chewing cycle. And so that, you know, in their head, they only have a certain chewing cycle. And by natural chewing, they're so used to that cycle, you don't want to force them to change their chewing cycle, because that's going to exacerbate more issues as well. And like balanced Lingualize, you can use in all the classes. Different advantage of it's a different setup technique, right? We haven't used it maybe, and we think it's odd. We think it's different. Dentists aren't used to it, and so forth. And maybe if it's not set up correctly, you know, the phonetics of the patient, you know, because of lack of incisal space freedom, sometimes if you're not careful and set that up, they may have some phonetic issues. So what does the research say between balanced and Lingualize? Well, if you really do a deep dive into the literature, you'll find that really it's a consensus that there is no consensus of which one is best for the patient. And that's really what we're trying to do, is provide something that's best for the patient. So a lot of the research talks about that the lingualized occlusion and canine guidance occlusion is as good as balanced occlusion, and maybe better. But these studies are back and forth, so there really is no consensus that which one is the best. So it really comes down to us, right? How are we communicating with the dentist? Are we getting the information on the proper chew cycle? Mr. Mark Wagenseal did a fantastic job a couple of weeks back about talking about these chew cycles, and to really look at that and try to determine how much opening do you need. Can you get away with a balanced occlusion? Can you do, how far off the ridge can you move depending on the patient's chew cycle? So I would hope that everyone gets a chance. We have a couple more the rest of this year. Again, class 2, class 3, and then a combination syndrome as well. Really good. Mark's a denturist, and he's done a really fantastic job to break this down and explain how to set teeth up properly. But there's a lot of literature out there, just no consensus. So how do we set up? What do we use? Generally speaking, what do we get? It's what the dentist prescribes, right? Usually it's class 1, shade A1. And that's pretty much all we get. Sometimes we get the molds, sometimes we don't. But there's really no information usually on what's that patient's chewing cycle. Some of them provide that information. Prosthodontists certainly do, because they understand the psychological and the biological nuances of chewing patterns. And that will help us design a proper setup for that individual patient, which is really what we're looking for. And just like crown and bridge or any other prosthetics we do, dentures should not be cookie cutter dentures. We need to look at what is that, the needs for that patient, whether it's a balance, whether it's lingualized. Do they need a flat plane occlusion, right? What can they tolerate? What best fits them? And sometimes we can do that just through the like a provisional denture, especially now that we have digital dentures. You can print out a relatively inexpensive try-in denture with different types of dentition occlusal setups. That's usually found in the software that you can do. And then we can decide, okay, do we use the Lingualize? Do we use a balanced occlusion, right? How do those teeth set up? The VITA teeth, of course, those are either lingual form or MFT, multifunctional teeth, stands for. Those posteriors are specifically designed to accommodate either setup, whether they're functionally balanced or lingualized occlusion. They have a 15-degree buccal incline on the upper and the lower, and then on the lingual, those are 20 degrees. So either way, you can do a balanced occlusion, come into contact multiple points, or you can do a lingualize where you just have that mortar and pestle effect that helps the patient too. But either one are designed to work in either scenario. It's just a matter of what the patient, what fits best. So on the economy side, it's a multifunctional tooth. It's just slightly different as far as the composition. It's more of a pure PMMA type acrylic denture tooth, whereas the premium, the posteriors, those have some silica to make them look more natural, more reflective as far as natural light. But these types of posteriors, they have no locking cusp, so the patient isn't, when they bite down, they're not going to come in contact deep into those fauces. They're not going to lock that denture up. It's going to allow, a couple millimeters play from the center of the contact point, left to right, so that the patient can continue to chew. It doesn't get stuck as they pull out or separate their jaws and then come back down. Lower posteriors have a facet. There's actually a couple facets on the lowers that are kind of flat plane that allow self setup, if you will, for those posteriors, as well as contact points. There's a contact point mesial distal that kind of fit in together. That's on those types of teeth, linguiform or multi MFTs. I went over the cuspal inclination. This does mitigate interferences no matter which way you set it up, and helps reduce the pressure points, alleviate sore spots by doing a correct setup with equalized contact points. So they're really nice teeth. They're also, the concept itself, either way, is also brought through digital dentures. VITA, we've got a denture tooth that's called the Vigo, which is relatively kind of the same concept, made it a little bit different for digital dentures. However, it accommodates either a lingualized occlusion setup, or you have a functional balance that you just bring these in. So either way, digital dentures might be the way to go. Either setup, you're always going to start off the same, right? We need that information. We need to have some anatomical guidelines, and then we need a good impression, whether it's scanned or not, to develop the teeth in the proper manner. So this tooth, this posterior tooth, whether or not it's in a conventional balanced occlusion or the same tooth, all we do is rotate the buccal out, kick it up, just enough to give the patient some freedom there to allow that 1 to 2 millimeters to allow so that there's no buccal interference when the patient chews. The only contact point and the only sliding movement is that lower and that little area that has the incline planes on it. And we can use it, set it up. This just shows you that the only contact sliding movement, deflective contacts are really isolated in that fossa. And then once that separates, once the jaw opens up, they separate out, and you no longer have any deflective, shear stress forces for that patient when they chew, which helps them out. This is a quick movie, kind of shows the concept of how the denture teeth kind of self-adjust. Again, there's like a little facets. They kind of self-guide themselves into the proper position. And again, you can always do manual set this up to 1 to 2 tooth position as well. It depends on what you're trying to achieve, what kind of arch it is, and so forth. But by allowing it to kind of self-guide itself into the right position, we're also talking about setup time, less setup time, less possible dentist try-in time. But this, again, is all relative depending on if the dentist or if you're getting and communicating with that practitioner, getting the right information so that you're not doing these over and over and over again. But it is possible that you can, adjust your setup technique slightly using teeth like this. That will start saving you labor costs because it's going to start saving you time to set up. And then, of course, just the time for you to do your finished wax up and so forth is always going to be the same. But again, the dentists as well, they're going to start saving time and money if you start working with them about communicating to you the right information. This is so important that you work with your dentist, with your practitioners on delivering the case to you, but also the information. Start working with them. And if you have to, educate each other a little bit, right? And primarily see what the dentures look, if possible. What do the dentures look like in the patient's mouth? Get some feedback post-insertion. If you can go to the chair side, that's fantastic. Most of us can't because we're doing outside work, but if you can see the patient and have observe the patient start chewing, see if the doctor's having to adjust the bite to spot check it, things like that. Are they being spot checked? Are they being adjusted? The occlusal aspects being adjusted, and now it's no longer lingualized occlusion, but balanced, or instead of balance, now it's all over the board. And so you have really no longer all that effort of you setting up has followed through with that patient because it's been adjusted inaccurately or differently than it should. And primarily this is comes around all the time. And this is something that happens to any tooth, right? I mean, it's not specific teeth, it's how we set this up. Are we setting up the teeth so that if we do have canine guidance, right, is it at a point where that it just barely goes onto the incisal, or is there still a lot of pressure solely on the incisors, on those cuspids, that are going to cause chipping? These little fractures, it's either here or it's a lower lateral. You see these, this is a bite issue. This is an adjustment issue. This is a issue in which we're not controlling the bilateral setup, whether it's balanced or lingualized. We are causing the patient, they are riding on too much force on the individual teeth. There is no tooth that can't be fractured depending on what the patient's chewing. We have patients that are undiagnosed bruxers. And a lot of times, if we look back in the chart, we see that patients have even fractured their own natural teeth, let alone then we can understand how it's possible that they can fracture denture teeth as well. So the denture teeth that we have, whether the economy, whether or not they're the premium teeth, there's all sorts of different teeth, just like everyone else. But we do that because we are not cookie cutter manufacturers. We make teeth to fit the indication of that patient. So we do have teeth that have more texture than others. We have teeth that look what I call the age denture, that are very smooth, flat surface, finished very flashy, glossy, and reflect light quite well. Those to me are more of a older age denture look, which is acceptable to many patients. And then you've got this other set of patient pools that likes cosmetically driven. I want it to look youthful. So youthful teeth usually are more textured. They're a little bit more translucent. So you have all sorts of different teeth that can be used in certain lingualized balanced occlusion type setups So you have all these to work with the dentist on and work with the patient and decide, okay, which one fits the best. Sometimes, let's face it, we know this. Some dentists are just used to a certain degree tooth because that's what they learned in the university, in the dental school. Nowadays, unless you're a prosthodontist, there's very little of actual physical hands-on setting up of denture teeth and processing denture teeth. It's really not done that much anymore. They usually now, they farm that out if they do that at all. So we have to make sure that we look at teeth that are like natural teeth. So the denture teeth, you know, we're looking at shape, the light, you know, the wear resistance. Are they going to be functional and prosthetically cosmetic driven? So we have to look at all those, make sure that we select teeth that are going to look like natural teeth. These are a couple teeth here. You can see the acrylic here, right? They did a nice job of trying to blend in the tone, the color tone, which is now another area in which is becoming more common, especially with digital dentures, because they're very plain looking, but sometimes you have to cosmetically adjust those tissue tones of a denture, the flange of it, to make it look acceptable for that patient and to blend in, because that's really what we're trying to do, whether it's a natural denture teeth or not. So, you know, we try to create the teeth, the contours, so they match natural dentition, you know, to avoid like what we call the gummy look, that avoid that triangle, if you will, of tissue. So we try to make it more proportional, right? Make them look more. There's so much data out there on natural teeth, the size, the golden proportion, the width and the height and so forth like that. So they're all aligned. The other thing that VITA does, even though the schematic kind of looks where they look the same, VITA's individual teeth, you can get a card of teeth from VITA, and let's say the centrals or the laterals or the cuspids, those are usually different. You don't mirror the two laterals or the two centrals or the two cuspids. And in nature, most teeth are different. They're not symmetrical. They are asymmetrical. They look a little different from left to right. So we make them appear slightly different. So some incised ledges may be broader. They may have some divots in it. But that's to accommodate making it look more natural. And that's what VITA tries to do, is build things natural so that they look like individual natural teeth and not a denture. So that's, but that part is also up to you, right? Which teeth you select, how to set up. You know, do you do cookie cutter dentures, or, you know, do you sometimes add a twist to a lateral or add a little bit twist to any of the denture teeth on the anteriors to make it look, you know, more of a mixed dentition? Or are they straight across? Are they chiclets, right? Which for many patients today, all they want is what? White, right? They want just flat, squared off teeth, very white, and they're happy with that. And they want to just show off to their friends. So all of these technologies, all of this information, all the contours, the natural look, it kind of spills over into digital dentures as well. The concept is with what we call Vigo teeth. Same thing, they're shaped more like natural teeth. They basically end up having a 20 micron gap between the denture base and the tooth, and then we use what we call bionic bond, which is an adhesive. It's a true adhesive. It's almost as viscosity is like water. So it's very thin, natural, adhesive. So there's very little fill material. That's not what we're trying to do. We're trying to bond the teeth, not to fill the gap because of errors in printing or errors in milling. We've got these down pat where they pretty much fit together, hand and glove. Of course, all of our teeth are manufactured from the at the factory itself. They used to be all handmade, hand layered. We're doing more automation today. But if you order the same mold, and one day you order one mold, and then next week you order the same mold. It is possible that the two molds, if you put them back face to face, they may look a little bit different, but that's VITA's philosophy that no teeth are exact. The mold is a baseline. It's average width and length and cuspid to cuspid. So they're basic measurements, but they're not always exactly the same because most of these molds are handmade, and then they're designed to be slightly different as the actual physical mold versus the mold that's on the cards of your teeth. So there's a little bit different. There not much difference on far as the manufacturing itself. We still use a 3-layer concept. All of our teeth are produced in one processing technique. Really, the only difference is that on our premium teeth, we use this MRP material, microfiller reinforced polymer. Basically, it's a silica that's cross-linked in with some of the resin itself and bonds itself. The MFT, as I mentioned, it's a PMMA, densely cross-linked acrylic, if you will, and then the Bionic Vigo that is very similar to the MRP material of the premium teeth, and it's considered the Vigo are considered a premium tooth as well in that sense, because they also have very unique wear properties. Even though the MFTs are just acrylic, they're very nice as far as wear resistance. So, you might not want to use MFTs for implant denture teeth because those will wear pretty quick. But on removable dentures, they're going to last quite a while without fraction, without cracking. You can adjust these without them causing microfracture and stuff because of the dense material, how they're manufactured. I mentioned there are 3 layers. There's a neck, enamel, there's a body, and then there's effects. We add in the opalescence, the fluorescence, and so forth. That's all built in. The shade itself is consistent throughout the tooth from outside to inside. So if you drill through the tooth, if you have to thin it out, it may become more fade, or the chroma may be less saturated, but the shade is still consistent with that shade guide. And then, of course, because they're manufactured in one process, the material, all of the layers, they're partially cured, but then at the very end, all the materials, they're homogeneous. They're all the same type of material. And all they do is do layers, and then they process it. At the end, it's one process under pressure, under heat, and make one homogeneous tooth. So you don't end up with a M&M type denture tooth that might break or crack on the shell on the outside, leaving a different material on the inside. Very highly polishable, very consistent with the shade guides, regardless MFT, the economy teeth, or the PhysioDens. The threshold of seeing the difference between the shade tab and the physical denture tooth is very small. VITA prides itself with its shade integrity, so they rely on manufacturing all of the materials very close to that shade tab that they produce. This is just an example showing how you can thin out the teeth at different thicknesses and still have a very consistent shade, if you will. Again, as it blends, as you thin it out, right, it may become more pale, right, but it still has the shade consistency. It doesn't change and gray out or become too translucent. You still get the body shade, that base shade out of it, no matter what you do. And I mentioned, fluorescence is also important because once the patient walks outside, you need that natural fluorescence to make them look like natural teeth, and that's the goal, right? To make them look like natural teeth. As far as translucency and opacity, right? if we look at denture teeth more towards the patient, what is the expectation of the patient? That's when we start selecting the right tooth for the right patient. If the patient says, you know, I don't want to look like I'm 16, I'm 70 years old, 80 years old, whatever the case may be, you know what, I don't mind having denture teeth. Well, maybe the VITA pan, which are a smooth textured tooth, maybe that's exactly for that patient. But maybe a patient wants to look younger, and as I mentioned earlier, maybe they need more translucent. Maybe the light, they don't want it to reflect too much because you want some absorption of that light to add a translucency so that it looks like a natural tooth. Just like natural teeth, they have scales or they have variances of translucency from the cervical all the way to the incisal. That's what makes it look natural. Different areas reflect light different, or absorb light, or transmit light differently. So you want to start selecting a tooth for certain dentists and their pool of patients. There may be another operatory, another customer clinic. So you'll find, some offices like a specific tooth form, shape, glossness, and that's pretty much all they stick to. And then you got others, offices that say, no, those aren't, they don't look natural enough. They're too reflective. They're too opaque. So you want to get them something a little bit more translucent, a little bit more younger looking. And the younger looking is we've got more texture, right? So if you look on the opposite side, you get a texture or a matte look on one side. That's going to make it look more youthful. That's going to make it look more dynamic. Or you're going to have more play of light, which really comes more into play if you're doing a partial denture. A partial denture where you're just really replacing one tooth, you have to start matching up the texture. Otherwise, if you place a smooth, glossy tooth in the adjacent to some natural teeth that have reflective differences, you can see the texture here, it is not going to work. It won't blend in, and that's really what we're looking for. Is at the end of the day, just like crown and bridge, we're looking to blend in these dentures for that individual patient. So it is all about blending in with functionality. So whether you choose the lingo form, lingualized occlusion, or you choose the lingo form and do a balanced occlusion, that one tooth can do it all. And then the rest is up to you as far as how well you set the teeth up, your communication with that dentist, are they providing you the right information? Because above all, we're all trying to make money. At the end of the day, we are businesses. We're trying to reduce time, reduce remakes, reduce resets, work with that dentist more often, try to educate that dentist. There are times where maybe you need somebody to come in and help organize a lecture that may help your dentist, your customers, understand what kind of information is needed, regardless whether it's through a traditional technique or through digital denture technique. Because let's face it, they both require almost the same information, and it has to be the correct information, otherwise it throws the whole denture off. And we have to start over, and we don't want to do all of those resets for nothing. So those of you that are looking for CE, at the end of this program, in a day or two, you should receive an email from us asking you to fill out a little bit more information so that we can get you a CE. We'll need your NBC CDT number and things like that. It has been recorded along with numerous other denture webinars, crown and bridge webinars, porcelain webinars, pretty much from the dentist perspective to the denturist perspective, on how to work with CAD/CAM materials, digital dentures, and so forth. So please visit us at any of our VITA North American websites, whether it's YouTube, the LinkedIn, the Facebook, and so forth. But those will be posted, and you can revisit it if you need to. Again, there are any of these social networks. If you want to give us a ping and let us know how things are going, and if you've tried different various things, you know, go ahead and give us a shout out, and you know, pose questions. You know, this is a family network, right? So we can try to reach out, and we kind of help each other. You know, we're not all in that much competition. So especially nowadays, where if you're a denture technician or a denturist, you are in great demand because there's really no more schooling for that, and it's all, you know, like it used to be on-the-job training in years ago, 50s, 60s, but then you only get really that one philosophy of setup, and then everything becomes cookie cutter. So if you need us here, give us a holler. Technical support hotline. There's the information if you want to get a hold of me personally. There's my direct line along with my email. My colleague Paul Richardson, this is his phone number as well. Paul does a tremendous great job as far as the digital denture work goes. So we have another digital workshop. If you haven't signed up, they're always limited because we actually do part hands-on, and we do didactic, just PowerPoint. So, but it's truly more of a understanding, a workshop where that we actually will send you a denture and some material, some denture teeth, and walk through you step by step on the digital denture process, and then you kind of follow us along. There is a price tag for that one, but nevertheless, you know, it's a fantastic job, and Paul really does a nice work there. So if you want to throw me any questions you have, please do it now. As I finish up, if you need to get a hold of any of your local reps, please do so. This is their information, whether you are in the U.S. and or Canada. Please give us a shout out, and we can help if direct you to the right person if we need to, and so forth. So we also have numerous courses, webinars, workshops that are through remote, as we're doing today. So join us again August 10th, August 12th. I mean, we have 3, 4 every month. We're almost at the point where we do one every week, and they're all different. So look at us on VITANorthAmerica.com/courses. You'll get a full list of all the courses. You can kind of sort through them, what you're interested in, what you're not. So we have some questions coming in right now, and let's get to that. So let's see here. In case of inadequate communication with the doctor regarding the bite preference, what do you prefer to do in lingualized occlusion or balanced occlusion? Most of your dentists are going to be more comfortable with balanced occlusion. So the first thing you need to do is contact that dentist and say, hey, I got your case looking good. You know, I got all the information I need if that's the case. If not, you tell them what you're lacking. Because without the dentist, without that customer knowing what you need, and you're not telling them that you don't have everything you need to do a perfect case or the best that you can, you need to reach out to them and ask them. And if you have a preference, you can ask the dentist, your client, well, do you care if I do balance or lingualized occlusion? So either the tooth will do either, but you don't want to get in hot water with your dentist. Maybe they're comfortable with seeing lingualized occlusion, and they are more than happy to accommodate you and allow that. So in a case where they don't tell you, I would reach out and start talking to them. It's a very good opener, if you will, to start talking to your dentist about something, about what it is they're really achieving, how are they doing, are they having trouble, are you having trouble, and so forth. So keep that information, that flow up. In a normal situation, what is the expected lifespan of the economy teeth? So economy teeth, which are primarily just PMMA, which in our system would be the multifunctional teeth, the MFT teeth. If you're looking at just conventional dentures, you can probably, depending on the patient, because that's very patient specific, that patient may burn through them in about 2 or 3 years, or it may be 8 to 9 years for that MFT. A lot of it has to do with how well the setup is, right? Is it fitting that patient ideally? And a lot of that, again, goes back to, was it a correct measurements provided to you? Were they correct? The articulation was correct. The impression, mucostatic impression, was that correct? Things like that. So very patient dependent on the premium teeth, if you will. Even on a dental implant case, a fixed denture or removable denture supported by implants, I mean, you're probably looking 6 to 8 years at the earliest where you even start seeing enough wear. Because ideally, on the premium teeth and the economy, but every time that patient walks into that office, they should be checking the bite, making sure that you still have functional balanced occlusion. And if the patient, if it's changed or if they start feeling sore spots, that's an issue of something not fitting, and or you've got too many deflective spots on those posteriors, and you need to correct that. And that's something that the dentist has to do. It's not always gonna fix everything just to do a reline or a rebase. It's not going to happen if the other aspects are not looked at. So again, whether it's economy or premium, the teeth are going to last really with the case specific, the patient specific, and how well it has been designed. Why is it denture education today? Is it due to digital evolution? So why isn't there more denture education? I think it might have been stemmed from my comment that universities are getting away the practical part of their curriculum. We work with a lot of universities throughout the U.S. and Canada, and it's more economics where that the dentists going through the school, the professors and so forth, they see that it's to their advantage. It's best that they do more of the practical clinical work as opposed to the laboratory work, because they are more thinking about, well, as a dentist, as a student, you're not going to do it on your own anyway. You're always going to have a laboratory or somebody else create these dentures for you. So they don't actually have the dentist sit down and even do their own crown and bridge. You know, it used to be when you, like California, which we're at, you used to have as a dentist to graduate, to take the test, the final test, you had to do your own inlays, your own onlays, your own crown, your own denture setup, and you had to pass that to actually get your certificate of dentistry here in the U.S. in California. They don't even do that anymore. You know, they're leaving it up to the dentist once they get out of school to work with those laboratories. And they do everything. What we have to worry about now, because it's a lot of the concept of dentures, specifically dentures, what we have to worry about is how is that denture being created? How is the dentist looking at the patient? Are they doing any measurements? Are they doing it correctly? And if not, we need to help them understand to use the right bite block, take the right measurements. Understand there are different molds, different setups, and so forth. So it's less about digital dentures, because in fact, digital dentures or the digital revolution. If you look at the crown and bridge side of digital chairside digital chairside, there's not a really huge spike in new offices coming out, purchasing CAD/CAM equipment. Same with the laboratories, right? We're so few now. Pretty much we're saturated, and until that price goes down enough, a lot of dentists are not doing becoming digital chairside. They have enough work without becoming a digital chairside and offering teeth in an hour and so forth. So we got a ways to go. We got a good decade to go before we're really out of work, in a sense, with not having to do digital work ourselves. Hybrid type zirconia, 5-6 types of cases. Is there an indication for lingualized occlusion? Well, this is a little bit different because the answer is yes and no. When you do have a fixed bridge, right, we're looking more towards group function, protect the individual teeth. And the only way to protect individual teeth is to ensure that we have simultaneously left and right group function as that patient chooses. So you can use Lingualize if you're precise. You can use a Lingualized occlusion. It's not necessary because there's no reason, for that fixed denture to start tipping. So you are therefore looking for more of a chewing capability and long-term stability as far as redirecting forces away from the implants and so forth like that. So kind of to answer your questions, you can get away with Lingualize or balanced occlusion, but it's a group function. Either way, you have to make sure that those teeth have group function when they're inexcursive, protrusive, and so forth. Otherwise, unfixed because it's so static, especially on zirconia. Zirconia fractures too as well. Everyone should know that there's nothing that's going to not fracture. So make sure that you do the right thing on occlusal aspect and help your dentist understand. Just don't go in there and start bearing down and grinding, spot grinding places. They have to have a philosophy behind them on what they're checking. Just high spots is not enough. We're looking at how the patient chews, the chewing cycle, the flective contacts and so forth like that. So if anybody else has any more questions, be happy to answer them. Otherwise, we're going to wrap this webinar up. It's been a little over an hour. So I want to thank everybody for joining us on today's VITA Learning webinar. Again, visit our website, visit our archive of library of various webinars that we have. Again, they're free. They're all about an hour long. They all have different information. You don't have to watch them all. We encourage you to watch the entire length of them. But, being on YouTube, you can always fast forward them, get to the area that you want to learn or revisit. But there's fantastic information that we're providing you to help you go better, learn more, become more educated, especially during these times where not everything's back together for in-person training. We're looking forward to that day, more in-person training, which we will soon, probably more like towards the end of this year. But right now, the remote webinars are working well. Please get a hold of us. If you have any further questions, you can always get a hold of us. These are the dates. Here is the possible reps in your area. You want to contact them as well, and they can help you out and guide you with what the different VITA materials are. And then, of course, if you need to get a hold of us, Paul or myself, we're available here as well, generally speaking, from about 6:30 to 5 p.m. Pacific Standard Time or specific time. All right. I want to thank everybody for joining us today. Everyone take care, and I hope to see you again. And this concludes another VITA Learning webinar. Thank you for joining us.